Welcome and thank you for being here. Thank you to our guests, especially Dr. Damon Tweedy and Dr. Jane Gagliardi. Thanks also to our wonderful Ollie at Duke Community Read Committee for selecting this book and collecting resources for our Community Read page. There's a link for that that's going in the chat if you haven't had a chance to check it out. I am Jenny Levine, Program Coordinator for Ollie at Duke, and it is my distinct honor to introduce today's guests. Damon Tweedy, MD, is a professor of psychiatry at Duke University School of Medicine, where he teaches and mentors medical students. He is also a staff psychiatrist within the Durham Veteran Affairs Health System, where he co-leads an integrated primary care mental health team. He graduated from Duke School of Medicine and then attended Yale Law School, where he focused on health policy and medical ethics before returning to Duke to complete his medical internship and psychiatric residency. You can read more about Dr. Tweedy on our website and in your copy of the book. He is also the author of Ollie at Duke's very first community read in 2021, Black Man in a White Coat. Jane P. Gagliardi, MD, MHS, FACP, DFAPA, completed medical school, residency training in combined internal medicine psychiatry, and her master's of health science in the clinical research training program at Duke, where she has remained on faculty since completing residency training. You can read more about Dr. Gagliardi in the link that Bettina is sharing in the chat. Dr. Gagliardi, Dr. Tweedy, welcome.
Thank you. Thank you so much. I was hoping to give a little more of an introduction to Dr. Tweedy, if possible, because I find him to be an inspiring thought leader. Looks like some of you who have had the opportunity to read one or both of his books can understand maybe why I think that, but I just wanted to set it with a little bit of context and maybe explain why it is that we are here talking today. So Dr. Tweedy's career in medicine started at Duke just a couple of years after mine. So we were both in medical school in the late 90s. And we both also went through training, Damon first in the Department of Medicine as an intern in that department before switching over to the Department of Psychiatry, and Jane, or me, starting out as a combined trained physician in both internal medicine and psychiatry. Dr. Tweedy's clinical practice has included being at the forefront of integrated behavioral health care and collaborative care, taking care of veterans who have brains that are connected to their bodies, as it turns out that most of us do. And Dr. Tweedy's academic career has included what I'm hoping he'll tell us a little bit about, like he did when he spoke to us at the Association of Medicine and Psychiatry, having deep thoughts that were initially unappreciated. But his first book, 2015's Black Man in a White Coat, became a New York Times bestseller and describes universal themes as well as some specific challenges that face our students and healthcare providers who are underrepresented in medicine, or maybe standing on the outside of a movement that seems a little bit different or separate from what they're doing. He has also published multiple perspective articles and thought pieces. He's been an educator and mentor for students in small groups, in interest groups, and in a variety of topics, really helping them understand who they are as human beings and who they are as health professionals, and is a collaborator on a number of projects, including some that I've been lucky enough to do, looking at racialized disparities in the care of patients in the emergency psychiatric setting. In 2022, he gave a really outstanding talk at Duke on Martin Luther King Jr. Day on the theme of ways that history informs the present. At the 2023 Association of Medicine and Psychiatry annual meeting, he gave a keynote with thought-provoking prompts, including, what are we doing today in medicine that we will look back on and wonder why we were doing those things, which I think, honestly, Dr. Tweedy might be a good lead into some of what we're hoping to talk about today. And then he has been doing some really important work elucidating the history of Malthias Avery with the Trent Center in a collaboration with Jeff Baker on the history of medicine and the history of race at Duke. So, Dr. Tweedy, I was curious if you could maybe tell us how you came up with the title of your book.
Yeah. So first of all, thanks everyone for joining in there's always other things you could be doing with your time. So I just want to let you know that I, respect that your attention and everything for that, for, joining us today. Yeah. So Dr. Gagliardi and I go way back to medical school, over a quarter century. So long time ago. Um, yeah, so I think I have this sort of penchant for, I am. You guys will maybe get a feel for this during this conversation. I'm not a confrontational person at all, but I do take on very contentious topics. I like to tackle and grapple with very, contentious topics. And so, you think about my first book was about, she asked about the title of the book, "Facing the Unseen," right? And so, let me say two things about that. On its most obvious level, mental health problems aren't. Um, as easily as characterized as, say, what we call physical health versus mental health. So physical health problems tend to be more easily characterized by lab tests and vital signs and imaging studies. Mental health problems seem more elusive, right? And so there's, in some way, there's this kind of unseen quality to it. And I think that often makes it difficult for people in medicine and in society to fully grapple with the true nature of how important they really are and how problematic they can be for so many of us, because there's this kind of unseen quality to it. And so, on its most simple level, the title is like this idea of like, how do we face that unseen? Because they're very, as much as we might think these problems are sort of elusive, they're very real, right? When we think about all the rates of mental health distress, we think about overdose deaths, we think about suicide. There's so many ways in which these problems are very, very real, and we have to get a handle on that. And so that's, on one hand, the facing the unseen. That that also, that's the one level of it. The other level of it kind of comes from this sort of ode to civil rights activist James Baldwin, the writer James Baldwin. He wrote an essay in the New York Times in the early 1960s, uh, and I wish I had, always wish I had it in front of me because I can never quite get it right. But the gist of it is that everything, we can't change everything that is faced, but we can't. Um, Let me know. Actually, I'm going to get this quote right because I have it right in front of me on the computer, and there's no reason I shouldn't just get it right for you right now and then do it justice. I don't want to do him justice, injustice. So here you go. Not everything that is faced can be changed, but nothing can be changed until it is faced. And so that's the quote from James Baldwin. So and I think, and he's talking about it in the context of race in the civil rights struggle. All the problems that we had, the history that we were facing, the momentous problems that were there, and how we can't change the past, but how do we sort of, in order to move forward, we must sort of face these challenges that are in front of us, as immense as they might be. And so I think there's a lot of parallels when we talk about so that animated a lot of my first book about race and medicine. So this current book is really about mental health struggles, and I think there's a lot to be said that's very similar. There's certain aspects about the mental health challenges that people face historically and even to the present that we can't be changed, but we can't make the progress that we need to make until we really sort of take an honest assessment and accounting of what needs to happen. And so I think there's a lot of parallels between the struggles of the civil rights movement and the challenge that we faced back then for Black people integrating into society. Uh, I think there's a lot of the same challenges that we face now in our contemporary time with people with mental illness and mental distress integrating into society, integrating within medicine. So I think there's some real parallels that I like to draw with both books.
Yeah, and it occurs to me, both based on some of the discussions we've had and also reading your book, that the idea of being a mental health expert may also create the experience of being a little bit on the outside. As you were talking, it occurred to me, Dr. Tweedy, that you couldn't choose the color of your skin, but you did choose to become a psychiatrist. Can you tell us a little bit about how you made that decision?
uh, Not the easiest decision to make. I think so. So. I don't know how many of you in the audience are physicians or close to physicians or no physicians in your own personal lives. But when you go to medical school, there's a certain sort of like uh, you can use the word hierarchy or certain sort of things that are valued in a certain way. And so when you learn medicine, you value the idea of like this quantitative quality to it. Numbers and interpreting lab tests, and then you learn how to interpret EKGs and X-rays and blood smears and all these sorts of diagnostic tests. And you also, how do you treat it? You value the idea of like doing surgery and procedures. There's a certain sort of culture that's really built upon that. And so psychiatry kind of doesn't have those things the same way to the same degree often that those fields. So it's very quickly becomes something seen as like, well, what really is this psychiatry thing? It's kind of on the outside. What do I make of it? Is it even real? And so those are some of the messages that I think a lot of medical students sort of come, and I certainly came to medical school embracing and felt it in early medical school because that wasn't what was valued. And now, Dr. Gagliardi may disagree with me here, but I feel like even the locations of where we even send students for mental health training signal some of those same messages. I think about how, my exposure to surgery and pediatrics and general medicine occurred at the main sort of campus, but my initial exposure to mental health and psychiatry occurred at an off-campus site, some 30 minutes away. And it was much more an institutionalized setting. And so, like, what sort of messages are we kind of sending about what this means and what we're dealing with? And so I think all those things kind of worked against the idea that I would ever take psychiatry seriously or become a psychiatrist, right? So I'd say that's a starting point. But you asked, Jane, how did I get from point A to point B, right? So yeah, it's a I think we should kind of come back to some of that later, but I would say there's many factors, some of which were like personal experiences where I saw a couple close friends experience mental distress in a way that I just couldn't have conceived of. Because I arrived in medical school thinking about mental illness as something very othered and different, kind of an us versus them kind of quality to it. And the idea that people that I could care about and be close to could suffer distress was an alien concept to me at the time. And so having some of those experiences as I got further in my training kind of opened me up to it. And the other thing I would say is also seeing how many of the patients with, quote unquote, general physical health problems had these other mental health issues that were clearly impeding their physical recovery, but were not being addressed or being ignored. And so those things really kind of just all kind of came together over time. And there were other things, of course, as well. I mean, just the honesty, the realization that, we think about how many, this idea of the mind and body being separate, but how often the two things are so intertwined, right? And so like the person comes in with, they present with mental health issues, but maybe there's a physical health cost to it, right? Or the converse, they have these physical health problems, but the mental health issue is really kind of the thing that's the most important in the moment. And they can sort of overlap and change over time. And I kind of found that fascinating, this sort of mind-body interface as I got further into my training.
Yes. And so this mind-body interface, can you describe a few examples that you've noticed where either it made sense that it was separated or it didn't make sense for that mind and body to be separated, especially in the care of patients, I would say. Do you have some examples that you could illustrate?
Well, the thing we kind of hear about a lot is this idea that like, someone has a mental health diagnosis or a label on their record or chart, and then they come in with physical symptoms, and perhaps the physical symptoms aren't characterized the same way. Maybe the medical provider is more likely to ascribe their chest pain or stomach pain to some sort of mental problem. It's not, and so you can see sometimes people particularly with more severe mental health issues, how their medical conditions might suffer worse because people are more likely to sort of box you in on this one direction. Okay, it's just a mental health problem. Maybe we don't need the same level of workup, but we might otherwise, right? So you see that kind of thing. But I would say but as far as on a more simple level, the mind-body interface, you just take something like depression, right, or anxiety, these really common things that people experience, and there's like so many different causes. But it's there's always like a medical workup that has to take place. Certain lab tests and certain things that, well, at least should take place. And it's just fascinating always. Like, I'm maybe a month or so ago, a guy comes in, he's very depressed. Primary care doctor kind of just sends him my way. And we'll talk more about that process later. But, just as something as simple as a thyroid test, and he had severe hypothyroidism, and just how that itself, it's like that's a physical health issue, right? But the presenting sign is this mental health symptom. I think that's like a really sort of fascinating kind of thing for us to even sort of think about, and how important that on just the most basic level. There's a more sort of complex story in the book I talk about where on the flip side, you have someone who's presenting with physical symptoms, but the underlying cause is some kind of mental issue we can't quite grasp our hands on. And that's the case where there was this woman who had like, she came to the ER and she came in with, she was basically more or less mute, but she had profound elevated blood pressure, heart rate was through the roof. Team couldn't figure out what was going on. And just something that really always strikes me. I mean, and hopefully we can talk about this more, Jane, because you know more about it than I do. The idea back then that the medical records were so completely separate. There was a mental health chart, and then there was a physical health chart, and that the doctors in the ER couldn't read the mental health chart. But you had access to the medical records, And so, I'm sorry, the medication list. And they actually called in a psychiatrist so we could just figure out what was going on in her mental health chart. So it's the idea that the systems were so separate, even within the same healthcare system, you couldn't even provide the right care in some sort of way, right? And so what ended up happening is the psychiatrist was able to look through the records and came to this determination that this woman had something called catatonia, which is a kind of a psychiatric, neuropsychiatric kind of thing, but it had this tremendous physical manifestation, and he was able to make the recommendations to the treatment team as to what could happen, and to sort of see her rapid recovery. It was just an amazing, again, amazing sense of how these mind and body interface, and how we lose things if we sort of treat them as separate entities. I think that's really the crux of it.
Yeah, and I recall the anecdote in the book. You were on the medical side at the time, maybe have already thought that you might pursue psychiatry, but still kind of wondering, well, psychiatry is a little non-quantitative. There's nothing you can actually do to fix a patient.
Exactly.
And you're seeing somebody who's in like a hypertensive crisis,
Exactly.
looking really, really sick. Maybe they have to send her to the intensive care unit.
Right.
Psychiatrist comes in, diagnoses catatonia, gives an injection of lorazepam, and
Yes.
boom, the patient's all better.
Yes. It was amazing because the ER doctors were baffled. I was in internal medicine at the time, weren't sure what to make of it. And so I was like, wow, this is a different way of even thinking about psychiatry, right? And so, yeah, it was amazing experience to see in that moment.
Yeah, kind of enlightening in terms of our ability to understand.
But Dr. G, I'm sorry. What do you make of that separate charts, the stuff though? Like the idea that we would have these record systems that were so separate and inaccessible. I know it's not. I know it's not that way anymore to a large extent, but it was
not
then.
Totally that way. But when I was rounding on the general medicine service last week, and I had patients whose, I feel like I need to see everything in order to take good care of a patient. I need to understand their whole history. And when I'm on the general medicine service, I have to break the glass, which means I have to put in a separate login to make sure that I really meant to access these particularly sensitive records. Now, on the one hand, the idea is that we're protecting people from unauthorized access to super top secret confidential information about their innermost secret desires and wishes. And on the other hand, if we're thinking, well, the brain is connected to the body, I can't actually know what's fully going on with my patient unless I know all of it, then that separation seems like more collusion with maybe the forces that you're hoping to argue against by writing this book.
Yeah.
So I'm not a fan.
Yeah. That makes two of us.
Yeah. So you had, we had two things that I'm trying to keep track of the things to circle back to so we can make sure to get there. And you said, well, we'll get a little bit later on the journey to become a psychiatrist. So, okay, I'm putting that on the back shelf. You also mentioned when somebody who's taking care of patients in a primary care setting kind of urgently needs your help as a psychiatrist. How does that happen, and how does that play into this idea of maybe separate and either equal or unequal healthcare systems for mind and body?
Yeah, so the traditional model, I mean, there's different types, but we know that it's much easier to get access to general primary medical care, and even subspecialty medical care than it is mental health treatment. We think about how our insurance system has set things up and what it reimburses, what it does not. The way that there's many mental health providers in the community who don't accept insurance for a number of reasons. There's so many barriers, right? So it's easy. So the person comes to their primary care doctor. We think this person has a mental health issue, and then what, right? We put that referral in, and this person either the person has to make all sorts of efforts to try and find a mental health provider, or like even in a system like the VA historically, there would be this referral would go into this kind of electronic, space where and it's like, is it gonna? And then someone might call the patient, and you could just see how there's so many ways in which this wouldn't kind of come together. And even if it did come together, for instance, the general medical clinics on the first floor, the general medical clinics on the first floor, the mental health clinics in the basement, in the back. I mean, there's just so many kind of messages that we're sort of saying about, what all this means, and do we take it as seriously? And you can see how that could impact patients' willingness to seek treatment. They have to make mental health treatment. You have to make extra efforts. You have to often call and look around and search. You have to pay. If you get treatment, you may have to go to a separate kind of place or building where it seems like something's wrong with you, and you have to pay more money. And there's just so many different ways in which there are just barriers left and right. So one thing that I do like about what I've done in the VA, when I started at the VA, it was very much that separate model, and I became a sort of the medical director of this program from its infancy, in this integrated primary care mental health program. And I do like, and what the whole theory about it is that you have to really meet people where they are. And so you're trying to embed mental health care into the primary care setting. So I think there's two advantages to it. One is that when it's done well, one is that literally the idea that patients can access the care more easily, but it also kind of disabuses us of this idea that they're separate things. Like if we're all kind of in the same building, the same location, even the same floor, well, we're not thinking, well, there's a physical problem and then there's this mental problem that you got to go somewhere else to deal with. So even just like last week, I was in the clinic in the Clayton office, and a primary care doctor reached out to me. He was talking to this patient. He's a middle-aged guy, and he was, it was a regular general medical appointment, follow up on blood pressure kind of appointment. And the patient starts like talking about, his difficulty in his life. And he starts crying, and he's depressed, and he's had thoughts about hurting himself at some times. And the primary care doctor was kind of like, well, what do I do? And he was going to send him to the emergency room, which is the kind of thing that would probably happen in the old system. To think about going to the emergency room and the challenges that someone might face if you go there. You might wait 6 hours. You still might not end up getting the care that you might have needed in the moment. It's really much more about, like, you work in emergency more than I do. It's really much more about, does this person need to go to the hospital or not? I mean, isn't that kind of what it comes down to, Jane?
It really does seem to be. The emergency department is a place to figure out in the hospital or outpatient management.
Yeah.
Mhm.
Either you go, it's an expression, either you go out or you go up, up to the medical ward, or you kind of go out. And that's really like the whole sort of thrust of it largely. And so but in this particular case, I was actually in a busy day. I just finished seeing some patients. I had a bunch of stuff to do, and I was like, ugh. But you know what? I didn't think that plan was a great one. I went downstairs. I was in the building, and I talked to this guy in the midst of his primary care appointment, and we spoke for 20 minutes or so. And we were able to save an emergency. I mean, he was clearly depressed. He needs mental health treatment, but he didn't need to go to the hospital. And we saved him an emergency room visit. Driving 45 minutes to the emergency room, we were able to get the treatment he needed to start then immediately, versus like this referral that might take weeks or even longer to get the care established. So I think that's like a system that we should be aspiring towards. I spoke with a family medicine doctor out in Colorado in preparation for the book, and he made this comment that he said that, some psychiatrists see this as a threat. Some primary care doctors see this as too much work for them. But he sort of said that, the truth is that there are always going to be people with more severe mental health problems where we're never going to not need psychiatrists. But what we really need is kind of this layer of mental health that surrounds all medical care. So whether we're talking about the trauma surgery department and people coming in, we think about fixing the bones and stuff and the injury, but there's certainly, this person's been shot, this person has whatever, maybe amputation. There's always mental health components to these things that people are experiencing, whether they're talking about the oncology clinic, diabetes clinic. These physical problems all have mental health challenges. It doesn't mean you have to have this is the other thing we should talk about. It doesn't mean you have to have a label or a diagnosis or to think that you could benefit from mental health or behavioral health services. I think that's one of the other challenges in our system, is this idea that you have to sort of be pathologized in some way to benefit from the services that could be helpful. So I think there needs to be this layer across all medical disciplines.
Yeah, so much to what you've just said. One is, I would say currently, if a behavioral health provider outside the VA would like to bill and collect, they do need to pathologize. That's the way the rules are written.
Exactly. That's one of the problems too. Exactly.
And I
David.
also see that we have a comment in the chat that is going to prompt my next question. You say in the book that after your first book, you had no intention of writing another one. And I would say to people who don't yet know Dr. Tweedy, my impressions of Dr. Tweedy are that, I was able to invite him to give grand rounds very shortly after his first book came out. And I would say he's not somebody who seems to seek attention or admiration even. And that sometimes seems a little bit reluctant to be in the spotlight, even though that's kind of what you have to do if you're going to be a New York Times best-selling author. What is it that activated you to go ahead and write this second book? How did you become so passionate about this that it overcame your reluctance so that here you are on a book tour again? And then I just have to say, we also all hope that you're writing a third, fourth, and fifth.
Let me just take the other part first. Yeah, it was actually, interestingly enough, it was on a Zoom meetings. So around 2021, this is when there were still a lot of the classes we were doing were still on Zoom. I was in a group with the second year medical students, and there's a course that I teach that I think is relevant to this topic. It's really, it has a long kind of fancy name, but basically I describe it as psychiatry for the non-psychiatrist. So these are medical students. So most people go to medical school are not going to become psychiatrists. 90-something% will not. And that's fine, but I think it's really important for them to be able to have a better breadth of people with mental health problems, and not only think about them as people who are really the most kind of severely ill people, or people who are the most distressed, and think about people in a much broader spectrum of what it means to have mental health challenges, but also to be able to succeed and do well in the face of those. And so this course tries to expose students to different settings where they can see mental health being delivered outside of the kind of traditional inpatient psych ward or emergency room. And so some of it's lectures, some of it's like going to other sites. In any case, because of COVID, we weren't able to do a lot of the site visits that I really enjoy doing, and taking students to other places. And so students were just talking about some of their experiences one afternoon, and they were describing a lot of settings where patients they were seeing in general medical settings. For instance, one student described working in a thoracic surgery clinic where people were, lung cancer, for example, is probably the most obvious thing you think about, and how there was no discussion about smoking and about quitting smoking. It's like, well, the most obvious thing you could be thinking about, people with heart disease and lung problems, smoking's a terrible thing, and how there wasn't even a discussion about, like, how do we work on helping people integrate into treating and treatment for it, evidence-based treatment, just like such a glaring thing, right? And how people and the doctors were kind of avoiding these conversations deliberately. And then just kind of made me think about how there was this clear disconnect that the students were seeing. And but I also understood those doctors' perceptions, because I was once that same way, where the last thing I wanted to engage with someone with is this long kind of discussion about mental health issues that I may or may not be able to fix. And so it made me think about, like, how do we get here to this place where these students are seeing these challenges, and then how do we get here, and then what could we do about it? And so those are some of the things that kind of animated my discussion, sort of made me think back to my own experiences and how my own journey to psychiatry, which is very sort of rocky to get here in the first place. And so I think that's what kind of led me to start thinking about writing about this topic in a broader way, because I feel like there was clearly this, while we talk about how mental health, there's less stigma now than there was 20, 30 years ago, patients are still suffering. And the system still fails people in many ways. It fails patients, but also fails doctors. And how can we do better? And so all those things kind of came together for me to sort of think about writing about this topic.
Yeah, and we're grateful. And for those who have not yet been able to get your hands on a copy of the book, I strongly encourage you to. If you haven't read the other one, so this is the book that we're talking about, Facing the Unseen. I have an autographed copy I'm really grateful for. As you're talking, I really do hear the resonant themes between the two books, as we were discussing just a little bit before we came online. And part of what I'm hearing is the structural issues that sort of permeate kind of race in medicine. Or somebody in the chat had said, I was at Duke from 75 to 86. Racial issues were quite significant at that time.
I'd like to hear more about that. But,
it would be great to hear more about that. And then the structure of the way the healthcare system is set up has kind of created these parallel tracks for the medical and the psychiatric care. And I think it's always risky to write about structural issues. How do you maintain your optimism, and how do you promote people to change?
Wow, those are some heavy questions. So you think about the structural issues with race, just to kind of circle back to one thing that I observed in medical school. So certainly, one time it was the most literally racial segregation, of course, through the early 60s. But even thinking about the idea, like, of even once that was gone, there was these sort of like public clinics and private clinics. You'd see that as a student. You rotate, and the public clinics would have this very much sort of like almost kind of all black patient kind of quality to them, and the private clinics would be this complete opposite. And you could just sort of see that even in sort of this parallel sort of thing setting happening. I think those are some of the same parallels with the medical versus the physical medical health versus the mental health clinics, and you sort of see the different sort of like qualities of care, standards of care, and how different they might be in these different settings. Um, how do I maintain optimism? Um, well, I mean, let's think about it. So I'm working on uh, things are not where we would like them to be. No one should pretend that they are, but like one of the projects that you mentioned earlier was something I'm working on, the history of Duke. I'd love for you guys, and this is probably a separate thing I'd have to come back and talk about another time, but we're looking at a case from the 1950s where there was a black person turned away from Duke Hospital because it was a segregated institution. And this person ended up being sent to the Lincoln Hospital, the black hospital at the time, and ultimately succumbed to their injuries. And looking at the sort of the structural things in place at that time. Like literally, there were Duke had a fixed number of black beds and a fixed number of white beds, and they were disproportionate to the population, and just really so very much the structural in the most blatant sort of we think structural racism. That might be the sort of a really great way to kind of think about it. Something as obvious and as quantitative as that. Um, and so that was very real, and even at the time that and so then in this podcast we talk about how Duke began to change and how the 60s took place and what happened in the 60s. Um, not pretending that everything was fixed because certainly it was not. But my parents are still living today, and when they were my age, they couldn't have gone to Duke. Right? Duke was literally prohibited black people from attending. Right? It was that obvious. It was that clear cut. Um, and so certainly over the years that I've been at Duke, and it's been worked, it has improved from that time. I mean, we can certainly admit to that. But it didn't just happen because people just said, "Oh, we should just do it." It took a lot of work. It took a lot of hard work from people, and I could list all sorts of names. And in this podcast, we list those names, we talk about them that make that thing happen, right? And so some of it was really hard. Some of it required them to reach out to people who might have felt differently about an issue from the outset. It required taking serious risks to themselves. And so I feel like in some ways, my work in talking about race, talking about mental health issues, it's just like an honor to those folks in the past and to sort of continue that progress, because progress, it won't just happen because we think it should happen. And it's just going to, it's all just going to come down from the sky and work great. We have to work hard, and people have to do that work. And so I feel like I'm just trying to do my sort of small part in making that work. And so one thing that I enjoy writing stories, but I've also feel like it's a way for me to connect to people who might not otherwise engage with some of these complex issues. Some of the things that feedback I've gotten from both books, in the first book, because it's been many years now, is that some people would really be turned off by, because you ask like my approach. Now I think there's different approaches. Some people have a fire in their belly and they're sort of aggressive and they're sort of like call people out. That's not my style. I mean, I'm not criticizing that. That's just I'm not a confrontational person at heart. And so I like to think we try and meet people, try and give people as much as I can the benefit of the doubt, meet them where they are, and try and I don't want to say enlighten it because that gives me too much credit, but try and help them see things in a little different way than they might have. And then maybe that can open them up to seeing things, into helping move things forward. So that's been my approach over time. And so some days I'm not as optimistic as others, right? But I think over the grand scheme of things, I feel like there's things are certainly better than they once were, and that I can still, in my mind, envision that better future, even though there's always last thing I'll say about this. There's always one of the things once you start learning history, which is why I think it's so important to study history. History is always a story of progress and backlash, progress and setbacks. It's never just smooth and easy. These are really hard things to happen, and so we know that we've seen this story. If you look back you go back to the 1860s, you go back to the 1960s, you see that in our current time. There's always progress. There's always challenges, backlash, and so I think we're facing that. But I feel like my role is just to sort of be someone. I want to be part. I know I'm sort of feel like I'm talking a long time, Jane, but I think it's a really important thing to say. So because I think one of the things about race is that some of the things that happened in the past, people will look back and say, geez, how could they have done that, right? How could these people allow these things to have happened? But I think that gives us I think it's easy for us to do that from 2024 to say, look back in 1964 and say, well, how could they have done that? How could they have not been better? Um, the truth is that there were people in 1964 and 1954 who were better, right? But they were fighting uphill. And I think the same is true for us now. So I think we have to look at our own times and think, well, what are the things that we're doing now that people might look back on and say, what were they thinking? What were they doing? How could they let these things happen? And I want to be part of that. People, when someone says, well, in 2024, there were people who were trying to do better and were working hard and saw the problems and were trying to do their best. And so I want to be part of that side of history. And I want the people that I'm sort of trying to reach and talk with to think about how they can be on that side of history as well.
Yeah, your inclusivity, I will just speak as somebody who read Black Man in a White Coat, and clearly I'm a white woman who went through Duke Medical School just before you did. The themes that you brought up really resonated with me too. So the way that you wrote that book felt quite approachable and quite resonant in a way that I do think has the potential to disarm people and help them meet you at the message you're giving. We have a couple of questions in the chat that I'd like to ask you about.
Sure.
This discussion seems to be starting from the physical health side of the mind-body connection, but what about starting from the mental health side, the enormous toll of psychiatric medications? So I can imagine this person might be talking about the metabolic syndrome that can come about from the antipsychotic medications, or maybe the movement disorders that might come about, or weight gain. Just that was one question that I see in the chat from Judy's iPad.
Yeah, well, there's a few things to think about with that. So I think, one of the things that I talk about that a little bit in the book, one of the chapters. How can I say this? Because there was another point I wanted to make too, but I'm gonna have to just sort of come back to it. See, I should be writing these things down like you are as they come to me, because I forgot that other point. I think there's a couple things to think about. So I feel like the medical model that we've sort of all kind of been indoctrinated to learn about as students, it has its strengths, right? Someone has a heart attack, there's a certain protocol that you work with to address the acute acute issues, and you can save their life. You break your leg, there's certain things that, acute protocols that can work to treat that, right? So there's certain things where the medical model works well. But there's so much else in which I think the medical model falls short. This is me speaking for myself, not for anyone else, but the medical model falls short in a lot of ways for a lot of physical health problems. There's so many chronic, issues that, you're not necessarily going to cure. And the medical model still only kind of knows one way of dealing with it almost. It's like medications, right? Medical model for, chronic pain, right? Pain is multifactorial. I mean, medicine can help, but there's also a lot of other things that may be even more important for an individual person. So I think in some ways, there's a part of the structure of the healthcare system, because of the way it's where you have to see patients so frequently and see them in such a short period of time, so many patients. There's just kind of a assembly line quality to it. And so that kind of discourages these other sort of approaches of thinking about health, right? And so like it's often easiest to just sort of like say, okay, X problem, Y treatment is medication or whatever, right? Or surgery. And so you lose a lot when you do that. And I think one of the challenges with psychiatry is that although psychiatry historically, you think about, well, it's especially where you can spend the most time with people and have the most, but in some ways, psychiatry has fallen under that grip of the medical model as well too often, where psychiatrists are in these settings where they're seeing patients for very short visits, and it's very reductionistic, and the outcome is often just medication. And you see people with very complex, large doses of medicines that maybe some people, this is not an anti-medicine screed by any stretch, because there's some people for whom these things can be life-saving and are very importantly and very needed. But for others, maybe they're on more than they need, for sure, and it can happen. And so that could be one aspect to it. So, I mean, I'm not sure I'm asking that question exactly, because there's no right answer to that question. But I do think that the medical model itself, in a broader sense, whether it's physical health as well as mental health, can often lead to sort of less desirable outcomes, because we're sort of seeing people in very short segments, and we're only focused on symptoms and maybe not the bigger picture. Because it's our system just needs to be kind of reimagined to think about how we can do that better.
So like if I even take an example that I believe I know from things I've heard you say and books I've read that you've written, let's say high blood pressure.
Right.
If I just reduce you down to person with this BMI, high blood pressure, needs to be on a beta blocker and an ACE inhibitor. I'm missing all of this opportunity to connect with you as a human being, with your rich experience and the various maybe stressors. We've got another comment in the chat about traumas that
Mhm.
may have been things you lived through or that you know about from people in your family that may have contributed in some way to your high blood pressure.
Right.
Can you
So,
speak on that and maybe your own blood pressure control?
I was gonna say, so Jane just gave me like a layup there. So if you have the basketball model there, it's like right there in front of my face. Can't miss that one, right? So basically, yeah. So it's just the idea that yeah, hypertension, right? High blood pressure. It's a number. It's so quantitative. Either you have it or you don't. You give this. You have a number. It's high. You take these beta blocker, ACE inhibitor, etc. Um, but often it's not so complex. It can be more complex than even we might understand at this point in time in terms of our sort of scientific knowledge. So as a medical student, my blood pressure was very elevated actually. I learned this when doing one of these sort of intro to medicine sessions. Blood pressure was high. Went to student health. They even found that I had some early sort of kidney abnormalities, which is of course is a complication of high blood pressure. You think, high blood pressure, kidney disease, dialysis, there's this sort of terrible pathway people can go on. Um, and so was that me? Right. And was that my fate? So that was something that I was worried about at the time. I took blood pressure medicines for a couple of years, actually. It did help some, but at some point I kind of was like, could there be some other thing to be thinking about? Like, I'm only 20 something. Is this kind of what I want to do the rest of my life? Could there be other ways I could think about managing this? So I did look into like some. I actually did some research in the lab where they looked at like sort of psychological approaches to dealing with blood pressure. But what was most interesting to me is that, I tried some of that. That never really stuck either. Honestly, I was so busy with life. But at some point in my life, several years later, of course, diet. And we talk about diet. Like, do we even talk to patients about what they're eating, right? And their access to food and why they may be eating the foods that they eat. Like, what are the associations that they might make? So, like, as a doctor, I might just tell a patient, well, you should just eat X, Y, Z because this is the right thing to do. But that's helpful on some level, but really we need to be connected with the person. Like, and how do we provide the kind of advice that might actually meet the person, show them that we hear them, that we're invested in this person doing well and doing better. What I'm saying? So that there's the medical side of it, but then there's also this idea of how do we connect with that person and make that person come back to us and then work with them as a partner to help them have better health. And so for me, I think this is kind of the thing that's sort of unexplained. So I'm 50 years old now, and my blood pressure has been normal for a long time, 15 or more years. But don't take blood pressure medicines. Don't follow some magic diet. Certainly not in as good a shape as I once was. I think it's very much the psychological dimension that we can only sort of fully picture. So when I was a younger person, there was a lot of stress with being a young Black person at a place like Duke in medicine. Do I belong? I had all sorts of racial kind of, I don't want to call them confrontations, but there's things that happened, a lot of things that happened where people would slight me, patients, doctors, insult me. I mean, all sorts of things, right? And it's just, and you're carrying all this sort of weight. You're carrying it. You're carrying this baggage with you every time you enter into these rooms, and you wonder how you're being perceived. Are you seen as dangerous? Are you seen as incompetent? You can just kind of go through the list of things that would sort of happen to me, and it took a toll. But I don't think I even so that could manifest as really raising your blood pressure, right? There's a whole pathway in which these things can happen. And so I'm in a place in life now where I don't have those same levels of distress. I'm much more sort of I've developed better coping mechanisms for dealing with these things. And blood pressure is normal, right? So how do we explain that? Like, how do we explain it from a physiological medical sense? These are the kind of things I think we need to be thinking about when we're engaging with patients. Like, yes, high blood pressure is a number, but what are some of the things that you're dealing with? And how can we help you with those sorts of things, right? So I think this is a much more complex thing.
Yeah.
Yeah.
We have a lighter question for you.
Yes.
Francis would like to know, you did a wonderful job on the audiobooks. Did you enjoy that experience? And I actually would have
Yeah.
to just say as an
Ooh,
aside, I had once
wow.
asked if Dr. Tweedy might like to read somebody else's The Faculty Letter on Cost
Right.
for sort of an audio experience. And that was maybe a little too traumatic at the time.
Right.
And I remember that you were like, well, that's interesting. I don't think I should probably go there. So tell us
Yeah.
about your audiobooks for your own writing.
Yeah. I it's just only for the second book. The first book, I was not the audio person. And so they approached me with this a few months ago. I mean, no, about 6 months ago now. And I was like, "Ooh, I don't know about that." And they said, no, we think that you could do a good, we hope think you could do a pretty good job with it. And it's your story. And as I thought about that more, I thought, yeah, you know, that's true. Maybe I should take a stab at it. I talked to some other authors who had done it. Um, it took a while. It's a long process. Just think about the idea of writing for, you know, reading. So we was broken up into like these 5 hour sessions, and reading for 5 hours.
5 hour sessions.
Yes,
Oh,
I know. Long, long, long. And the thing that's the funniest thing for me was realizing once you read something out loud, even if it's your own words, I thought to myself, because when you're trying to, you know, read these words, it's like, man, this is hard to say. Why did I use this word has 4 syllables. This sentence is way too long. Why, if I would have known I was going to do this, I would have written in very, like, very
who wrote
short
this book?
sentences. Exactly. Who wrote this book? Why did I use all these big words trying to sound like I'm intelligent? Just keep it simple. So that was a lesson that I learned. So if I ever do that again, I will be writing very simple, much more plain language.
Well, that leads right into talk about layups. Can you talk a bit about your writing process?
Yeah. So writing is something that's you know, this whole thing started as a medical student, not with the idea that I would ever be writing books, but really as a way to sort of like kind of manage life, cope with life. People use that word process. I think that's a word people use a lot. Um, make sense of your experiences. It was only later that it became something more than that. Um, so writing is something sometimes that I feel like I have to do at this point. Like I write stuff now all the time. Some of the stuff I know will never sort of see the light of day, but it's like something I feel like I have to kind of just do to kind of get my mind right. Just like some people have to like I know you're like a marathoner, right? Don't you do like you do marathons or do you do like
I
yeah.
haven't in a long time. I'm old now.
Or even triathlons, don't you? 'Cause I'm picking on you now. Yeah, so some people have to, you know, have different needs, and so writing is one of my kind of my needs to sort of like, you know, kind of feel like I'm centered or feel right. And so, but in terms of writing a book, though, you really have to have some sort of process because it can easily days things just kind of slip by, and you're like, man, I haven't done anything. And so I decided for myself that my goal was going to be 300 words a day. Now, that doesn't mean that those 300 words are any good because half the time they're not, and you have to kind of start over. But it's just the idea that I'm going to commit myself to writing 300 words a day on average. Because there's some days where you don't do any, but there might be another day when you have more time and you can do 600 words. And so then so my goal is to have that 300 word average over a period of time. And so I actually was, particularly when I started writing the book, when it's hard and the hardest part, because the hardest part is that blank page. Because once you can kind of get over that blank page and get words out, ideas can more easily kind of come together. And so I had to I had a little kind of a spreadsheet, and I just had, you know, the date and the number of words that I wrote, and just I did that for at least a few months until I really got jump started. Yeah, so writing is good for your mental health. Well, at least it is for me. Yes, yes, yes. So that's the process. So it was also very deliberate and intentional. I had to get a certain number of words out on the page, and then I could always go back and try and make it better.
And you've talked now twice. I heard you yesterday about the first book title and then about your Facing the Unseen title. Both times there's a very concrete,
Right.
like looking at the things you can't see. And then there is a more metaphorical or historically referenced. Did you have to come up with the title before you started on that spreadsheet, or did that come along the way?
So with the first book, the title just kind of came to me. So ironically, speaking of writing being good for your mental health, I'll tell people I think showers are good for your mental health because in both cases, you know, the idea that the shower cleanses the body, but I think it also kind of cleanses the mind. And so for me, both titles for my books came. I was in the shower and then just left the shower cleaning up, and then the idea kind of came to me for both books. I mean, this is the absolute truth. And so, Black Man in a White Coat, yes, literally, like I'm literally a black guy who wears a white coat. At least I did during the time that I was writing the book. But there's also a bigger metaphor for what that means about race in medicine. So yeah, was that the question you asked me, or did I get solely sidetracked?
I was really just wondering if your title came first.
Oh yes.
Or if you started writing first.
So for the first book, the title came first. For the second book, no, I was struggling with the title actually. And then we kind of had this back and forth with my editor, and they had some titles that I really didn't like. Like they didn't like my first title. And then it came back with some titles that I really didn't like. I was like, there's no way we're going to go with that title. And so then finally, after some more back and forth, it all kind of came together that this was the title that sort of made the most sense.
The other question that I would have about your writing process, as you're doing the 300 words per day, are you still working, or have you gone on some sabbatical and you're just sort of doing nothing but writing? How does that?
Oh gosh, I wish. Maybe that'll happen in a few years, but for the current time, yeah, no, it's been So those 300 words, sometimes they happen at from 11 o'clock at night. Sometimes they happen at 6 o'clock in the morning. You know, it varies day to day. Sometimes it'll be a Saturday afternoon where I might be able to get 600 words, so it varies.
Carpool line, waiting for your kids.
Exactly, exactly. Varies a lot.
And I see that we have about 9 minutes left, so I
Yeah,
want to be thoughtful about the questions that I asked you next. I do, there is a question here about whether you're seeing progress
yeah.
for veterans of military service being
hmm
open to getting help with their
hmm
mental health issues, more so
Yeah.
than veterans in the past.
Yeah, so maybe I should just say a little bit about how I even got to the VA part. So, the VA is certainly built into the training of the Duke residency, so you have exposure to it. But for me, there was a much more sort of personal connection. I think I mentioned this to you in one of my other settings. But yeah, so I come from a family of military folks. My dad was in the Navy, um, in between the Korean War and Vietnam War. My grandfather was in World War One, his father. And so at the time, of course, the military was segregated, and the black soldiers in France, basically what they did was their job was to bury all the U.S. soldiers in these mass graves. That's what the black soldiers did. And so my dad said that his father never said anything about that. He only learned about that from someone else. So getting this idea about people carrying to carry that with you, right? The idea that you never were able to sort of talk about this thing that you had done, and you'd seen all these hordes of dead bodies and corpses, and you just sort of piling them on top of each other. That was his experience. I had two uncles that were in World War II in the South Pacific. One of them discussed they both had significant alcohol problems. One was able to sort of function with it, if you will. The other was not. Ended up being homeless. Was treated at the VA, and was not probably treated so well, at least according to my father. And so these are some of the experiences that sort of led me to even work at the VA. This idea of sort of trying to do better, to give back to honor my own family in its own way. So the question is, have I seen progress? So compared to the experiences certainly that my grandfather had or that my uncles had, there's been tremendous progress. The VA, though, certainly suffers from shortfalls in terms of staffing. There's so many challenges that we still continue to face. Even the model that I work under, because of the staffing issues, the limitations to the kind of care that we could certainly get. But are people more open to it? Yes, absolutely. Is it perfect? Absolutely not. So I would say that's how I would sort of kind of characterize where we are now. But we are certainly much better than we once were, and we're certainly making progress towards a better place.
And I see actually this last question in the chat ties right into the question I had prepared to ask you, Dr. Tweedy, as we were
Yeah.
thinking about closing. And so I'm going to read the question in the chat, and then I'm going to ask my own question.
Yeah.
So this is, can you talk a little on fixing a broken mental health medical system where poor and minoritized people are treated differently and mental health is often not accessible, such that mentally ill people end up in prison?
Ooh, there's a lot there.
Yeah, there's a lot there. My question was, if you had the ability to wave a wand and make the healthcare system work well for everyone, would you continue to have mental health carve-outs? Would there be separate clinics? Or how would you design that system? I think they're related questions.
Yeah,
So
yeah, and
what
I'll
do you
tackle.
imagine is perfect?
Yeah, and I'll tackle some of what that person asked as well in their question. But yeah, I would say I think that there needs to be mental health services built into all the medical systems that we talk about. So there's going to be an oncology clinic, right? There's going to be a cardiology clinic. There's going to be these things, and they need to happen. But there needs to be mental health services that are sort of tied to that. Now, that doesn't mean all mental health services need to happen there, but there should be a first line mental health services that are tapped there in those centers, and then those mental health providers can then be tuned into the more specialized or separate kind of mental health treatment that we might think of as a more traditional model. But I think there needs to be that kind of bridge to that other thing. There should just be like a cancer clinic and then a mental health clinic and nothing kind of in between. There needs to be that sort of mental health bridge in between. I think that would be the sort of the first line. Clearly, we need to have health insurance needs to be something it's a necessary component to this sort of better healthcare for all. It's not going to solve the problem itself, but it certainly has to happen. And of course, we know that there's still plenty of people who are not insured. There's different tiers of insurance and there's different standards of insurance that still leaves us with separate but unequal care. The more we can sort of, work against all those things, the better off, we need to be. So I think those things definitely need to happen. if I think about a system standpoint. I also think that we need to, it's getting back to this other guy's, sorry, to Lisa's question. So I do take, one of the things I do in this course is I take the students in this course to the Durham County Jail. And there they actually get to see how much mental health care is delivered in that setting. And they begin to really be thinking about that, right? And to understand that this is a setting where people are delivering care. And how does this happen? How do we get to that point? What are the problems with that? Is it because we decided to dismantle our mental health system, to close psychiatric hospital beds? There's so many other things that I think that, so all those things are kind of there, about fixing the broken system, right? How do we deal with these sort of things? So do we need more psychiatric beds? Yes. But do we also need more kind of what I call, because right now the model is mostly inpatient hospital stay, that often kind of goes for people who are, there's often short-term, brief, acute, and then there's like this outpatient care that's hard to access. But the people need something in between. A lot of people need that kind of in between, like an intensive outpatient experience, a partial hospitalization. But those things are mostly only available to people who have money. And why is that, right? And how can we make a system work better? So these are the kind of things I think that could fix a lot of these problems you're talking about, and leaving people in the dark, the way that they are. So these are all things that need to happen. But it has to happen at so many different levels. It has to happen at a level of like, how do we even think about mental illness? How do we talk about it? What is the language we use to talk about people with mental health problems? These are all the kinds of things that we need to be thinking about. And just, I guess, kind of a hot off the press sort of thing. I am going to be talking, I don't know if I talked to you about this, Jane, or not. Maybe this should be just, yeah, so I'm going to be talking to, I got invited to talk to some, you know, some representatives at the national level. And I'll be actually going to be flying out tonight to talk with some people tomorrow morning at the Congress, at the House of Representatives, and just be talking about some of these issues. And so hopefully, I don't think I can just, me, one person, I'm not going to change all this stuff. But if I can just share some of these messages to the folks who are policymakers, and then maybe they can do a little bit there to the next level, that's how we begin to really make change. And so I'm really happy to be able to looking forward to that experience tomorrow. And hopefully that'll be a way to sort of translate some of what I'm talking about to this bigger picture.
Yes, and as anxiety provoking or big weeky as it is, say, for me to be interviewing you or for you to be talking to people in political leadership, remembering that human connection and sharing your anecdotes, I believe to be really powerful. And I appreciate all of the work that you're doing on behalf of society.
Yeah, there's a quote from Dr. King that I use a lot in sometimes my talks, and I'll say it's something to the effect of, if I cannot do great things, I can do small things in a great way. I like it because, it makes us think about, where do we fit within this larger universe? These problems have preceded us. They've been centuries in the making. But what can we do as individuals in our own space to sort of, we can throw up our hands and complain, or can we sort of take actions that can help people in our own sort of orbit? Now, some of us have bigger orbits than others, but we all have some orbit in which we have the capacity to help others and to think about how we can sort of begin to counter narratives. I mean, I'm here before you today as someone you might say, well, I was always destined to be here, writing books and being a doctor. But it took people to help me get here, and that people outside that it could see something in me that I couldn't see in myself. And so I think I just encourage all of you listening to think about how you can do that, how you can sort of help leave the world a little bit better than how you sort of came into it. And if we can all do that, then I think, we'll be a lot better for all of us.
Thank you so much. I think we turn it back over because it is 5 o'clock. Thank you, Dr. Tweedy.
Thank you, Dr. Tweedy. Thank you, Dr. Gagliardi. I think you are doing great things, and thank you for inspiring us to do great things and for being here for Ollie at Duke. Another testament to Dr. Tweedy's thoughtfulness. He encouraged us to promote the next community read. And we don't have one yet. So please send us your suggestions for a community read to ollie@duke.edu. And in the meantime, read this book and talk to one another about it. I'm so excited for your journey to speak with representatives about the importance of this type of healthcare. It should all be healthcare. So thank you both for your work and for joining us today.
Yeah, thank you for having me. Thank you, Dr. Gagliardi. Thank you, everybody in attendance.
Thank
All
you.
the best.
Have a lovely evening.